I present to you the newer trajectory for percutaneous S1 screw, a prospective analysis. Now we know the anatomy of the S1 pedicle. It has a large diameter, a short pedicle size, it is highly cancellous, and it lacks a cortical ring. On top of this, the L5S1 is a transitional motion segment with an oblique disc space. These increase the shear forces acting at this level, and all these factors lead to an increased S1 screw loosening by 41%. The known trajectory to us right now tells us to take the entry point 5 millimeters caudal and 10 millimeters lateral to the superior articulating facet, angulating the screw 20 degrees medially and parallel to the superior end plate. The screw length achieved by this technique is maximum by around 35 to 40 millimeters. The other trajectory, which is the neutral anterior trajectory, gives us a maximum length of 30 millimeters. So in the early 2019, we started this prospective analysis and included over 117 patients who underwent an L5S1 MIS TLIF with us. We introduced 234 percutaneous O-arm guided CT navigated S1 pedicle screws and evaluated them on the basis of the length, the entry point, the caudocranial angle, and finite element analysis. This technique mentions the entry point to be taken 15 millimeters distal and 10 millimeters lateral to the base of the superior articulating facet, aiming the inferomedial quadrant of the pedicle. The caudocranial angle being 60 degrees and the lateromedial angle being 20 degrees. So this is a short video of the technique of introducing this percutaneous screw under O-arm. So after passing the tap, we confirm by extending the in the direction of the screw, and we tap the pedicle under navigation guidance. And here we see the position of the screw, which is occupying the inferomedial quadrant, which has a 60 degrees of caudocranial angle, and it takes a good purchase at the sacral promontory. I would like to present a few cases included in our study. We operated a 17-year-old female with back pain for 2 years with bilateral lower limb radiculopathy and a claudication distance of 100 meters, who had L5 and S1 spina bifida. She underwent an L5S1 MIS TLIF with us and showed an excellent outcome at 6 months post-operatively, and we were able to place 6.5 by 45 millimeter screws at the S1 pedicle for her. Another female who underwent an MIS TLIF with us, a 41-year-old female with chronic back pain and bilateral lower limb radiculopathy, we were able to put 6.5 by 45 millimeter screw for her. Another 36-year-old female with a high-grade listhesis who shows the classical inverted Napoleon hat sign on the AP X-ray underwent an MIS TLIF, and we were able to manage to put a 50 millimeter screw in the S1 pedicle for her. So overall, we had almost an equal number of male and female patients in our study, and out of the 234 screws introduced, the mean length in males was found to be 45.9 millimeters, and that in women was found to be 44.8. And the caudocranial angle was around 50 to 65 degrees depending on various patients. Now, in order to understand the strength of our construct, we did a finite element analysis wherein we used the OptiStruct software, which is an AI assisted tool which helps in understanding the strength of the object which is under evaluation, and it gives modifications according to the structural changes that might be needed in with respect to strength, elasticity, and the pull-out strength of this thing. So when we introduced a solid cylinder and gave it a lordotic angle onto the software, it talked about two important forces that were acting on this cylinder. One being the displacement forces, which on this contour plot shows that it is maximally acting at the cranial end of the rod. So our cranial angulation of the S1 screw reduces the angle of the fulcrum at the lower end of this construct so much that it increases the pull-out strength by several folds to counter the displacement forces acting at the superior end. The other contour plot talks about the elemental stresses acting merely by the shape the lordotic shape of the rod, which acts maximum at the inferior end, which is at the place where it is fixed onto the S1 screw. So a longer screw with a bicortical hold reduces the forces acting at this point. So these two analytical studies ultimately tell us that the construct is strength-wise superior as compared to the conventional trajectory. Another advantage is that sometimes, due to the convergence of the tulips in obese patients, the conventional S1 screw trajectory, the sextant device can get stuck. However, in this trajectory, it ensures an adequate distance in between the L5 and S1 tulips for easy rod passage. So to conclude, this new trajectory of the S1 screw with the entry point caudal to the standard point and the caudocranial angulation increases the scope of longer screw placement, that is about 45 or more millimeters in size, which provides a more stable construct at this level. The limitations being that this trajectory of S1 screw placement is possible only with the MIS technique and is easier with navigation, but it could prove to be very challenging with open surgery. These are my references. Thank you.
This tricortical trajectory, the whole world does.
Yes, sir.
I think no one had the courage to get up and ask you. I've been doing this for years. It's a tricortical trajectory. You take any textbook on MIS, still if done with the sextant or whatever, you'll say it's the same radiological picture. I'm sure those who do MIS regularly, are there any differences in what we do? He's just documenting his trajectory. The novelty is different, so he's presenting his case. So he has named it under himself, so that's fine. He has done some work and documented. The documentation is very important.
That is being achieved.
No, sir. So the fusion, it actually has the entire construct into the picture. Because of the length and the direction of the screw, it just strengthens and ensures a better fusion rate, sir.
Did you compare with the bicortical strength compared to this?
This is not a comparative study, sir. So
we are
doing it parallelly right now, but this is not a comparative.
So what did you compare it with?
So we have just made, basically our follow-up is only to look out for implant failure in terms of breakage, pull-out or loosening.
Any difficulty for adjacent segment because of the rods which are looking quite oblique?
As of now, we not
slightly lateral for the patient. If goes to you, it's fine, but if it goes to an open surgeon?
Yeah, as of now, we haven't encountered that, sir, but
okay.
It can be, it is possible.
Even as far as finite element studies are concerned, it is said that the angulation between the tulip and the rod, if it is more angled, the stress is even higher compared to what the tulip should have been with the right angle at the rod.
Yes, sir.
So,
sir, the angle in between the tulip and the rod, that is where the polyaxial tulips come into the picture. But I am talking about, in our study, we are talking about the angle of the screw as compared to the rod, talking about the lever and the fulcrum, which increases the pull-out strength.
Yeah,
that is the strength that is being documented.
This entry point is slightly close to the TPDC, the transpedicular, transdiscal, transcorporeal screw. Yes. It's coming close to that. The trajectory goes from below upwards to the S1, L5.
Yes, sir.
Okay, thank you.
Thank you, sir.
We move on to the next presentation. Dr. Hanson. Yeah. Long-term outcomes of minimally invasive TLIF in lumbar degenerative diseases.
Hello. Good afternoon, everybody. My paper is on long-term outcome of MIS TLIF in lumbar degenerative disease. I am Dr. Hanson, and this study was done under the guidance of my mentor, Dr. Hitesh Modi, sir. So, 266 million people globally and 69 million people alone in Southeast Asia suffers from a lumbar degenerative diseases, and minimally invasive method reduces incision-related complications and are cosmetically superior. This method causes less injury to paraspinal muscles and ligaments, leading to better outcome than the traditional approaches. This study examines the outcome of 180 patients who underwent MIS relief between 2014 and 2023. So this is a retrospective study, and all the surgeries were done using tube and microscopes, and screws were inserted over wire. And the inclusion criteria were the back pain and leg pain for at least 6 weeks, unresponsive to conservative treatment, 1 or 2 level of lumbar canal stenosis or spondylolisthesis, and we included for at least minimum of 1 year of follow-up. Exclusion criteria were more than 2 level involvement, previous spinal instrumentation, and traumatic spine. The preoperative evaluation include detailed neurological examination and radiological imaging, static and dynamic X-rays and MRI. The observed parameters were estimated blood loss, hospital stay, operative time, surgical complications and revisions, and we measured the functional outcome using VAS scores and ODI scores post-operatively and on follow-up. So on results, we included 180 patients. The average age was 53 years. Average follow-up was 57 months. Single level studies were done in 94 patients, and double level surgeries were done in 86 patients. So in observed parameters, the operative time was average 131 minutes, and it was slightly higher in double level surgeries. Estimated blood loss was 137 ml, however it was a little bit higher in double level surgeries, and hospital stay was 4.2 days, which is almost same with the double level surgeries. And the complication, the 19 patients out of we had complications, which is 10.5%, which include radicular symptoms, persistent numbness, cage back out, adjacent level disease, hematoma, infection, root sleeve injury, screw breakage and screw loosening, out of which 7 patients we did revisions. In outcome, we measured the VAS scores and ODI scores, which were significantly improved post-operatively. However, the lumbar lordosis and pelvic incidents were maintained. So on to the discussion, the MIS TLIF offers benefits over open TLIF, including reduced blood loss, less tissue injury and faster recovery. The study maintained post-operatively pelvic incidents and lumbar lordosis with significant improvement in VAS scores and ODI scores. The complications rate were around 10.5%, which is aligning with the literature, which is 11% to 31%. The similar studies done by UB and Hamser et al. Also showed that there is a less anxiety, pain and better functional recovery with improved VAS and ODI scores in MIS TLIF. So to conclude my talk, MIS TLIF reduces perioperative morbidity compared to standard open TLIF. Benefit includes less blood loss, reduced post-operatively pain, shorter hospital stay and fewer surgical complications and early ambulation. It also causes less anxiety and improves VAS and ODI score. So MIS TLIF provides better functional outcome on a long-term follow-up in properly selected patients. Thank you.
Yeah, nice paper. And how did you manage to get long-term follow-up of all the patients?
Sir, this is just a long-term follow-up study, and it was done for a single surgeon study, sir.
Yeah, how did you manage to get 8 years follow-up of patients? You called up or
yes, sir. The
telephonic?
Some patients, sir, when they came in the follow-up, we took the follow-up, and some patients we did it on telephonically.
You've not shown any whole spine imaging for sagittal parameters?
Pardon, sir?
Not shown any images for whole spine X-ray scout films?
Sir, I didn't.
No, you have not correlated radiology with clinical outcomes. You have not done sagittal balance. Is there any novelty in your work?
Um,
Can you say that my work is novel because of these reasons?
Sir, it was just a long-term outcome.
And even for a long-term follow-up, even open surgeries which were conducted 10 years ago,
Yes, sir.
even their paper could be very, very similar to your paper.
Yes. So it is just to show that on long-term follow-up, and for further studies, sir, like.
For brevity, we will finish the discussion. We'll go to the next paper. Thank you.
Okay. Thank you.
One question. Is there any difference between the complication rate between single or multi-level TILIF?
No, there was not difference.
So same complication rate with either a 1 or 2 level?
We didn't compare the single and double level complication.
Okay, thank you.
Thank you.
Next paper we'll call Missabcon, MIS oblique lateral interbody fusion 2 years outcome.
Good afternoon everyone. Thank you chairpersons. I am Dr. Missabcon. So I will be sharing my experience of 2 years outcome from a single surgeon's learning curve experience of MIS OLIF in lead degenerative lumbar spine disorders. So as all of you are aware that there are many techniques and approaches available to address these issues. So why MIS OLIF? Because it can avoid complication related to dura or nerve root handling seen in posterior approaches, or exiting nerve root complications, or lumbar plexus injury seen in DLIF or endoTILIFs. So this was a retrospective analysis of clinico-radiological outcomes, and all the known complications were prospectively analyzed during the learning curve of MIS OLIF. So as you know, adopting MIS OLIF, especially in early career, can be challenging sometimes because of ideal case selection, approach related complication, apprehension about achieving indirect decompression, and tackling longer surgical duration and radiation exposure. Especially young surgeons are less well versed with the open retroperitoneal approaches. So the idea is to move from the base of the Miller's paradigm from base of nose to epitome of DUS. So this was conducted for the duration of 3 years with longest follow-up of 3 years, and 28 segments of 22 patients were analyzed in study. All the patients met following 3 criteria: back pain with radicular or the neurogenic claudication which got relieved with rest, and patients having failed conservative line of management and showing instability on X-ray or MRI. Any patient having rest pain, neuropathy, positive nerve root tension sign, infection, trauma, disc prolapse, facet cyst, severe bony stenosis or lysis more than 3 grade were excluded. All the patients were analyzed clinically and radiologically thoroughly, especially patients having grade 1 or more lysis. CT scans were done to analyze severe bony stenosis. All the patients underwent cage insertion from the left side. During initial learning curve, I tended to avoid MIS OLIF, especially in patients having Shiza's grade C or D stenosis and grade 2 or more lysis. For initial 7 cases, I kept gastrosurgeon as standby to avoid any approach related complications. Artificial graft was used in all the patients. None of the patients were staged. All the OLIF cage insertion and fixation was done in same stage. I didn't use neuromonitoring. Some key technical aspects: utilizing bolster to gain access for L4-5 space, avoiding pin distractors especially at L4-5 level, and if at all putting it very close to the end plate, and confirming your orthogonal maneuver position in AP as well as the lateral views. Clinical assessment was done using modified Magnep criteria. Radiological assessment was done on X-ray using SurgiMap software, and percentage improvement in foraminal height, disc height, reduction of lysis and segmental lordosis improvement was done. On T2 weighted axial image of MRI, pre-op and post-op assessment of improvement in overall canal diameter was done, and all these data were analyzed using PET-T test. Known complications were prospectively studied like vascular injury, peritoneal damage or psoas paresis. Moving to the demographic results, as you can see, majority of the patients fell into the category of obesity because average BMI was 27.7. The most common pathology was degenerative lysis, and significant number of patients fell into comorbidities including cardiac as well as diabetic comorbidities. The most common level addressed was L3-4 level because of the wide corridor between the great vessels and the psoas. None of the patients I did direct decompression, and single segment fusion was done in 20 and 2 segment fusion was done in 2 patients. The clinical outcome was excellent in 91% of patients and good in 9% of the patients. There was overall foraminal height improvement of 20.78%. Disc height improved was almost double. It was close to 97.32%. 7.1 degree of reduction of the listhesis was achieved overall. Segmental lordosis was improved by 3.16 degree, and overall spinal canal area improvement was 46.54%. And I also divided the patients into two categories: Shiza's grade A and B and Shiza's C and D. So more the severe the stenosis, more the amount of canal clearance I could achieve. It was as close as 67.5%, and all these parameters were statistically significant as p-value was less than 0.0001. Estimated blood loss, it was roughly around 50 ml, and it didn't change much over the course of learning curve, but the significant bleeding was in one patient where I had encountered iliolumbar vein rupture, which was controlled with using bipolar cautery and the flow cell, and patient didn't have any significant clinical consequences. The estimated time for single cage insertion, it didn't vary much after 10th case. It was somewhere around 45 to 50 minutes. Per operative complication, the significant complication I encountered was superior end plate fracture in severe osteoporotic bone, but I used undersized cage in that patient using a good amount of bone graft. And post-op complication, the most common was the transient psoas paresis in form of paresthesia of left-sided anterior thigh, which got resolved within 6 weeks. Just one patient had superficial wound infection. None of the patient required direct decompression. So this is very notable case during my early learning curve. I ventured into this patient to perform MIS OLIF, adult female with L4-5 degen listhesis. As you can see, the corridor was quite narrow. I couldn't reflect the psoas quite back. So I had to turn the patient back and went for MIS TLIF. I also compared my data with another series presented by June Saito et al. There wasn't any significant demographic differences, but the amount of disc height improvement and spinal canal area improvement, there were some significant differences in my study. The complication wise, two series went hand in hand. I just had one more vertebral end plate fracture, but none of the patient required direct decompression in any of the series. So this is one case example: 62-year-old female patient with 4-5 degen spondylolisthesis, obese, diabetic and hypertensive. As you can see, it's Shiza's grade D on axial scans, and if you can appreciate the post-op scan taken at 1 year follow-up, you can see the amount of indirect decompression that can be achieved using MIS OLIF. And also, it is not just the immediate indirect decompression, but also ligamentum flavum does undergo some remodeling and the thinning. So OLIF can be a good procedure if we want to achieve indirect decompression. So to conclude, MIS OLIF can be adopted even in your initial career. It doesn't have a steep learning curve. This study has demonstrated significant clinico-radiological outcomes even on long-term follow-up. It provides excellent deep indirect decompression in severe lumbar stenosis. However, prudent case selection based on clinico-radiological parameters. As I said, I excluded some of the patient. It is very, very crucial. Understanding its limitation and knowing and salvaging all the known potential complication is very important. These are my references. Thank you.